All right. Excuse me. Hello and welcome, everyone. This is Caleb from Tasc at the National Rural Health Resource Center. Today is Wednesday, May 15th, and we are here for the May Task 90 webinar, where we will be discussing the fiscal year 2018 Emergency Medical Services, or EMS, Flex supplemental funding projects, as well as some program updates from our Federal Office of Rural Health Policy partners, as well as Arkeita, the Flex monitoring team. We will discuss some of the new EMS resources to be released shortly, as well as some of the some updates to the ET3 model, the Emergency Triage, Treat, and Transport model from Kevin Mcginnis from the National Association of State EMS Officials. Before we get that started, I will encourage everyone to dial into the phone line so you can participate when questions and discussions, the portion of the webinar for questions and discussions. You will join the webinar muted, so *2 will unmute your line if you have any questions during discussion or updates, and please utilize the chat feature if you have any questions or discussion points before that. Again, this is Caleb from the Tasc team at the National Rural Health Resource Center. We have a few updates coming. The June Virtual Knowledge Group webinar will focus on health equity. Be on the lookout for a save the date shortly. The registration is currently open for the reverse site visit, and the hotel room discounted hotel block expires on June 10th. So be sure to register for the reverse site visit. That is in DC again this year, just across the street from where we were last year. The Tasc customer satisfaction survey is out now. Please respond. We do appreciate the time and attention that you guys take to complete that, and we really do sit down and make changes to our programs and projects and TA and things based on the results of that survey. And then, excuse me, we will begin the first of our two transition to value or advanced payment model learning collaboratives will begin next week, and then the second of the two learning collaboratives will begin later this summer following the reverse site visit. If you have any questions on that, please don't hesitate to reach out to me. And I believe Sally is going to provide Sarah's updates from the Federal Office of Rural Health Policy, as our federal partners are in a staff retreat today. Sally, are you there?
Yes. Good afternoon, everyone, or good morning to those way west of Minnesota. I'm providing the policy update on critical access hospital Influx-related updates, and the slides you're seeing are provided from Sarah Young at the Federal Office of Rural Health Policy, and there are links in the slides to these proposed rules and announcements from CMS. The first one is a proposed rule that impacts inpatient prospective payment system hospitals, and this was a wage index update that is being proposed by CMS, and this would look at the disparities between high and low wage index hospitals, and they're trying to balance between. It is a budget neutral, so some hospitals would have a reduction and others would have an increased but they're trying to remove the big discrepancy between them. And there are organizations looking at the impact of this across in terms of reductions. The American Hospital Association is looking at it on a state-by-state basis, and the NRHA has looked at it, the rural to urban. The COP payment for ambulance services is another proposed rule change, and direct graduate medical education and indirect medical education, and some changes for medical education occurring at critical access hospital. So those comments related to IPPS are due by June 24th, and you have to follow that mechanism and CMS to propose comments. They do respond to all comments, so it is important if they respond to them, and then they do look at the trends in comments and concerns before the final rules come out. The next one is regarding draft hospital co-location interpretive guidance, and this is clarity on how CMS and state surveyors look at hospital space when they're sharing or contracted staff arrangements, and this really impacts rural when they have visiting specialists come in, or different providers, behavioral health providers who are visiting, and provides some updated language in terms of what can be co-located, such as a waiting room versus other staffing arrangements. So that is a new language for survey process, and the comments are due July 2nd. Then the next one is related to EMS, and this is exciting given our topic today. And this looks at emergency triage, treat, and transport, ET3. And this it's been for Medicare enrolled ambulance service suppliers, and would provide a NOFO opportunity this fall for up to 42-year cooperative agreements. So this is something that to watch for. And then there is a CMS primary care initiatives, and this was rolled out by Health and Human Service and CMS and CMMI kind of in a wave of press releases and presentations in April and May. And there's some new payment models to transform primary care, both at smaller primary care organizations, and then looking at high need organizations, and even direct care. So the first one is called Primary Care First, and builds upon the Comprehensive Primary Care Plus model design that was tested and or implemented in selected states. And so this is driven by clinicians rather than the revenue cycle and administrative pieces. So again, the goal is to improve patient outcomes and satisfaction, and reward efficiency. And then there is another innovation model under direct contracting, a set of voluntary payment model options to reduce expenditures and preserve or enhance quality of care for Medicare fee-for-service beneficiaries, and proposes a risk and earn rewards arrangement. And those direct contracting models there's 3 different options. Those comments are due next week, May 23rd, and they're looking at a professional primary care, primary care model, and then the global and geographic population-based payment, PBP payments. And again, NRHA and HA is looking at the impact and whether this would fit into the provider-based rural health clinics. So I do encourage you to, within the hospitals in your state, and looking at the different models that CHs have within systems or independent or provider-based rural health clinics, and coordinating the impact for your hospitals and how this would play out specifically in your states. And there are some links there in terms of the questions related to specific regions for the geographic one as well. And Sarah, I want to share if you have questions on these the policy updates and submitting comments or the impact of these. I guess again she encouraged you to reach out to Rural Policy at HRSA.gov at the Federal Office of Rural Health Policy. So Caleb, I'll turn it back over to you.
All right, thank you, Sally. And Sally let you know what the address is if you have any questions on the policy updates. And next we have Sarah Brinkman from Arkeita, the Rural Quality Improvement Technical Assistance Center or team, to provide Arkeita updates. Sarah, are you there?
I am. I just have a few updates to go through. We've been in touch about most of these things, but it's just another opportunity to share. So we wanted to extend a very big thank you to all of you who pushed out the opportunity for the Emergency Department Transfer Communication Pilot regarding the revised measure. We had a ton of interest from hospitals and actually reached capacity much earlier than we anticipated. So we're in the process of going through getting business associate agreements in place for all of those hospitals that are going to participate in the pilot. If you are interested in or wondering about what the timeline looks like for getting information out to all of you, there was an email that was sent out from Yvonne at F4HP from the Mpquip at HRSA.gov email address. That included the measure change summary and a timeline of when we anticipate things will be ready. So as a reminder, the pilot is for hospitals to help us test out the instructions for the revised specifications, and we'll be taking their feedback to consider potential tweaks to wording in the instructions themselves. The revisions to the specifications came out of a technical expert panel that met last year, and there won't be any additional changes to those specifications specifically. And then we'll be developing some education that will be rolling out broadly next fall, and the new measure will go into effect January 1st of 2020. In the meantime, we are encouraging you to strongly encourage your hospital to continue to report the measure as it is currently stated as one of the core Mpquip measures, and that will count towards their meeting their eligibility requirements. In the meantime, we want to remind everyone that abstracting for accuracy is an option. So since we had such a great response to the potential participation in this pilot for the EDTC revised measure, abstracting for accuracy is an option for hospitals that are interested in just going through that inter-rater reliability process that Robin Carlson, as our quality and reporting specialist, is able to offer. And actually, I saw earlier that Kai is on the line from Wisconsin, or that she's logged into the call. We got a great example from Wisconsin of how they received a testimonial or sought out a testimonial from one of their facilities that participated in abstracting for accuracy and are using that as a promotion to their other hospitals. So if you're interested in seeing what they came up with, I'm sure Kai would be happy to share, or we can share. We really want you to be able to leverage the hospitals that have participated and found it useful to help others access that opportunity. We wrapped up the focus groups with the high-performing critical access hospitals for antibiotic stewardship in April. We did 4 focus groups, and we had 35 hospitals participate over those 4 calls. So thank you again to those of you who had hospitals that were identified and helped to facilitate that happening. We'll be pulling together what we learned and developing a resource for other critical access hospitals that we anticipate will be available sometime in late June. In late June, we also have our next Mpquip Virtual Knowledge Group call. That's on June 27th. So just as a reminder, we did reschedule that from the original date of June 20th, which overlapped with the Western Flux Conference. So June 27th, we'll be pushing out updated registration for that June 27th VKG, as well as the other 2 remaining VKGs for 2019. And then in the coming weeks, we did change platforms. So if you've registered and you have it on your calendar, the same time and date apply, but you'll be receiving new registration information for the Zoom platform, which we'll be using going forward. And on that June 27th call, we're still in the planning phases for that, but we do plan to review updates to the methodology for what we're now calling the Mpquip performance standards. They were previously referred to as the Mpquip quality improvement benchmark. Or you may have heard people use the acronym QUIBS, so we're moving away from that. We're calling it the Mpquip Performance Standards. So we had a VKG about that last summer. We had a couple of focus groups where folks were able to provide some feedback about the methodology this fall. We've been working on it in the meantime and now want to provide an update to you all on this June VKG call and hope that you'll participate in that. And then just a reminder that we pushed out a new resource when we sent out Mpquip Monthly for the month of May called the Quality Improvement Basics module. So this is a series of 11 modules that were developed in-house here at Stratus Health as part of our role as Arkeita, and specifically they were developed to support the small healthcare provider quality improvement grantees, but they were developed with a very general audience in mind, including critical access hospitals and state flex programs. So this is posted on the Stratus Health webpage, but you can do a search on the Tasc website for QI Basics, and you should be able to find it there, the link to access those modules. We are going through a pilot project right now with some of the quality grantees to do a facilitated peer learning network, and from that we'll be developing a facilitator guide that you'll be able to utilize to be able to pull together groups of folks who want to go through the QI Basics courses together in the future. And that is kind of my high-level updates that I have, but I'm available for questions as well.
Great. Thank you, Sarah and the Arkeita team. Star 2 will unmute your line if you have any questions for Sarah or the Arkeita team, or please utilize the chat feature to ask any questions now. All right, hearing none, I will ask John Gale from the Flex Monitoring team to unmute his line utilizing Star 2, and we'll hear some updates from the Flex Monitoring team.
Great. Thanks, Caleb, and I appreciate it. Sorry I was a little late getting on board. I was not having success with the phone number. So I'll just go briefly. Excuse me?
Oh, just said no worries. We're glad to have you.
So I'll just report briefly on some things that we have going, and then I have a favor to ask of some of our state partners in the State Flex Grant program. So from the Minnesota side, they have recently published Their state and national hospital compare quality measures, so they're available on the FMP website. We have published recently a couple of different policy briefs, one on the follow-up evaluation to the innovative models work that we've been doing. We did this past year, as well as a summary of EMS activities at the state Flux grant level. So those are all up on the website. And we're all continuing with our ongoing work. We'll be producing the state and community benchmarks probably about towards the latter part of June. We've had some issues getting the sorting out some hospital cost report data that we use for that. So they'll all be available. One of the big projects that we have going on is a collaboration with the University of North Carolina, and we're doing a joint evaluation of the work that states are doing to support financial and operational performance improvement. North Carolina is doing the qualitative piece. You may remember the brief that they did a few years ago, but we're trying to make it much more targeted and control for some of the variables and the influences that might skew the results. The piece that we're doing is a qualitative analysis of what the states are doing. And so when I say this, please be aware, we're not conducting these evaluations to put anyone on the spot, to call anyone out. That is not the purpose of our work. The purpose is to learn about what the states are doing so that we can share that information. So we'll be looking at issues related to implementation of state activities, but we're going to jump into specific target areas. So we've selected some states, and we'll be contacting them shortly related to the in-depth assessments that they've done with a select set of vulnerable hospitals. We'll be reviewing charge master programs, lean management, benchmarking, and some of the direct technical assistance related operational performance improvements and revenue cycle management. So we're really going to try to dig into this, and I've had my staff preparing sort of overviews of each of the specific areas of activity to begin to identify how we capture and measure the outcomes. So many of these interventions are not going to necessarily drastically overhaul the performance of any given hospital, but it will make a difference. And so that we'll want to really understand how you're identifying outcomes and tracking them. So you will be hearing from us within the states that we've selected within a week or so, and we'll be asking for some program materials, some of the assessment reports, and schedule time to talk with the Flex staff in each of your states and anyone who you think should be appropriately involved. So we'll hopefully we'll look forward to working with you, and we're excited about this project because I think this is a significant area of Flex activity, and it's important for us and the office and all of you to understand what's working well. How do you advance the effectiveness of these interventions, and what are the right things that should be done to try to support the hospitals we all work with. That being said, I think that's a quick wrap-up of the things that we have in the mix at the moment. I don't know if there are any questions.
Great. Thank you, John. Star 2 will unmute your line if you have any questions for John at the Flex monitoring team, or utilize the chat feature to the left of the box.
And before I forget, I should also say that we've also are working on with Minnesota and North Carolina enhancements to the Compass data query system. We are upgrading the site and realizing that one of the challenges we've had to date is merging and working with 3 different data sets, the hospital level financial and cost report data work that we're doing with quality, which is really much at the state level, and we have to suppress some small numbers. And then our county and community-based population health information. So those upgrades are being rolled out, and we hope to have all of that up by the middle of the summer.
Great. Thank you, John. Last call for any questions for John with the Flex monitoring team. All right, hearing none, we will go to Nicole Clement at the center to discuss some of the new upcoming EMS resources that we should be seeing very shortly. As we get ready for that, please take a moment to help with ensuring that our webinars are meeting your needs and desires by completing some of the polling questions.
Thanks, Caleb. Hi, everybody. It's Nicole at Tasc. Over the past 6 months or so, you've probably heard me say a number of times that we received some supplemental funding this year for some extra EMS activities, and all of that is actually coming to fruition, and you should be seeing it actually released and disseminating here in the next month or so. But just a reminder of what those things are. Similar to the population health portal and the readiness assessment that's already on our website for rural health organizations, we are putting something sort of similar together for rural EMS to take to gauge their readiness for the transition to value. So that is going to be coming pretty soon. I've got the first draft of that, and we're working on edits, so it's really happening. Also, we have some guides in the works. One of them is about EMS integration, and that document includes some tools and some different things for EMS agencies to use and think about as they're thinking about how they're going to integrate. We are also going to do some spotlight videos. 3 of those are planned to or confirmed right now. Those will be about fiscal year 2018 EMS sustainability project. So that Flex programs are working on, like I said, 2 of those are confirmed, and I'll be getting the 3rd one confirmed here soon. So hopefully we'll see those by the end of the program year. And then the other thing that we did is convene a small group meeting in March in Tampa, Florida. That was the Rural Emergency Care Integration Summit. We had 5 state Flex programs, and a couple of those were actually the state office director representing. We also had a rural EMS provider or 2. We had some state office EMS folks there, as well as an ambulance network and a critical access hospital, and then a couple of other subject matter experts as well. So that happened in March. We also have brought that group back together to discuss the summary document and received feedback from them. So that too is in its draft stage and should be out soon. So those are the things that I have coming. You should see those soon. The next thing on our agenda then is to introduce Kevin Mcginnis from the National Association of State EMS Officials. Kevin is a program manager for the National Association of State EMS Officials. He served as the state EMS director in Maine from 1986 through 1996. And received the Maine EMS Board Governor's Award in 1997. Since leaving state government, he has served as a consultant for government, hospital, and EMS provider clients, specializing in service evaluation and creative system building. Kevin is the communications technology advisor to 5 national EMS associations and specializes in EMS system development in community paramedicine and rural EMS. Kevin, I will turn it over to you. It's *2 to unmute your line.
Hi, this is Kevin Mcginnis. Can you hear me?
Hi, Kevin. Yep, I hear you.
Hi there. I'm sorry, I tried to make slides available from a program that we had this morning. I have them on my computer. I don't know if I can be made a presenter so you can see my computer or not.
Sure. Andy, could you pop up a new share box and then give Kevin presenter rights so he can share his screen?
One moment. Kevin, are you able to hit share my screen?
I just did.
Kevin, is it not letting you hit the arrow and then say share my screen?
Yeah, I've done that a couple of times now. Let me try one more time. I hit the arrow, share my screen.
Kevin, do you want to start emailing, or do you want to email it to us and then we can load it in as you start talking?
I would. I'm afraid I'm in a location in a hotel where email is not working right now. Perhaps I can just go ahead with a description.
That works. Thank you.
Okay. I'm sorry that didn't work. We just had I'm at the National Association of State EMS Officials annual meeting, and we just had a presentation by the Deputy Director of the Emergency Triage, Treat and Transport Project for CMS, Nina Brown Ashford. And I was going to share her slides with you, but I will tell you that at this point, they're on the verge of releasing a request for applications for the ET3, as it is known, program. And they were not able to share that with us today. They expect that application to go out in a PDF format, not as the actual request, but to inform potential applicants as early as possible what some of the detailed ground rules and qualifications for applicants are, so that people can start to plan for components of the program that they want to put together, such things as if they're going to have alternative destinations for ambulances program that they can start soliciting alternative destinations that qualify for the program, things like that. They are expecting that they're expecting that the program is going to begin accepting applications this summer. So, at any rate, let me go. I'm going to go down through and utilize some of her notes. The program, ET3 program, was announced on Valentine's Day this year, and it's something that has been a long time in coming. We've been pounding on CMS's door for many years now, telling them that the incentives for reimbursement need to be realigned away from bringing all patients by ambulance transport to the most expensive place to treat them, which is the emergency department. And so in the past year or so, they have had a conversation between the director of the Centers for Medicare and Medicaid Innovation and actually a colleague of that director, who is the New York Fire Department medical director, which resulted in developing what is now the ET3 program, which is actually data realignment. They're now confronted with a couple of things. One is CMMI has the ability to bring programs out fairly quickly. And that's something that they obviously would like to do here. On the other hand, there are obviously a lot of stakeholders involved in this, that including state EMS officials, including rural health folks, including everybody that delivers EMS services. And so there's sort of a competing interest of getting this program out as fast as possible, so that the EMS industry can take advantage of it and the patient marketplace can take advantage of it, and yet to do it right with the right kind of review in advance. So let me just tell you briefly at a high level what comprises the program as we know it now. And again, we are not going to know a lot of the details until that request for applications comes out. And again, they're trying to get that out within the next couple of weeks. She thought it might be available today, but it wasn't. There are two basic programs. One is aimed at ambulance services who are enrolled Medicare providers. This program is intended to allow those providers to, rather than taking all 911 calls and being forced to either go to the emergency department as they do now, or just simply having patients sign off for whatever reason as they do now, to have the option of providing treatment on the scene with then not transporting the patient, but having actually provided definitive care, or to have provided some definitive care on the scene or temporizing care on the scene, and then delivering the patient to a destination other than the emergency department. In both of those cases, it is for calls that are generated by a 911 call only. And in both cases, there must be a Medicare enrolled practitioner either on the scene providing care, and EMS providers, EMTs and paramedics are not Medicare enrolled practitioners. So it must be a doctor or mid-level practitioner or somebody actually providing the care on the scene or consulting via telehealth and guiding the EMS crew on the scene, or in making that decision to go to an alternative destination. So those are the options. Provide care on the scene and do not transport. Provide care on the scene and transport to an alternative destination. And in both cases, consult with a Medicare enrolled practitioner. Telehealth is defined, they say it's defined the way that Medicare now defines telehealth, which means a video-to-video connection. And there are obviously reimbursement implications about telehealth at play here as well. The other part of the program, part 2, is aimed at local government dispatch centers that dispatch ambulance services in 911 circumstances. They will be solicited later on in the program to do essentially nurse triage of calls, and the requirement for applicants for that type of agreement will be dispatch centers that are either local government run or under contract designated other centers. Those centers must, in order to qualify, be dispatching a service that has already has applied for and has been accepted as a participant in the first category for ambulance services and providers, the first thing that I described for alternative destinations and no transports. So those are the 2 programs. Program number 1 for ambulance suppliers and providers is expected to go out to about a third of the Medicare enrolled ambulance services, or be available to involve up to a cap of about a third of the Medicare enrolled ambulance services. As far as we know, the dispatch centers are expected to be limited to 40 or so around the country. One moment. There will be a payment for ambulance services and providers that are enrolled in the first program will be eligible to receive a payment based on either ALS or BLS fee for service, as is now defined by Medicare for that episode. There will also be the practitioner providing telehealth guidance for those calls will also be eligible for a telehealth reimbursement for that service provided under the current provisions that CMS has for telehealth payments. The timeline on all of this is that this is intended to be a 5-year pilot project beginning in January of 2020. In summer of 2019, the request for application release will occur. They're expecting that to be July 1 officially. They will then have an application process they expect in fall of 2019 to announce the participants for that ambulance service component, the first component I described. In the fall of 2019, they expect to have a notice of funding opportunity and OFO release for the dispatch, the first wave of dispatch participants. And in early 2020, they expect to award the cooperative agreement to go along with those the dispatch component, the second component that I described. It's going to be a 5-year program. There are going to be waves of applicants accepted over that 5 years. People, or I should say ambulance services that come in year 3 will be in a 2-year program, year 4, a 1-year program, et cetera. And that essentially describes what we know about the ET3 program. There are resources and contact information which I will share with Nicole Clement, who can get it out to you all. And I can also share this whole set of slides, which you did not get to see, and I apologize for that. I will share that with all of the folks that are on the line. And I'm glad to take questions.
Star 2 will unmute your line if you have any questions for Kevin. And we will be sure to distribute or share those slides with the recording of the webinar archive.
Great.
All right. Next on our agenda is and thank you, Kevin. Thank you for that overview of the ET3 model. And we recognize and appreciate that it was earlier this morning that you heard a fair amount of that. So we appreciate the quick turnaround on that.
And I do apologize. I'm sitting in the lobby of a hotel with meeting goers all around me. So I apologize if that didn't come across quite smoothly.
No worries. We appreciate your time and your willingness to join us, given that you're in the middle of a meeting.
Thank you.
The next item on our agenda is to hear from some of the EMS sustainability projects underway now, and the first on our list is Tracy Zayak from the Bureau of Community Health Systems in Kansas. We'll take just a second to get Tracy's slides loaded. Are you there, Tracy? Star 2 will unmute your line.
Can you hear me?
I can. Welcome.
Hello. All right, so I'm Tracy Zayak. I'm the Flex Coordinator for Kansas. So I'm just going to talk for a couple of minutes about the project that we're doing for the fiscal 18 EMS sustainability funding. Next slide, please. So what we decided to do was to partner with Ohio and the Paramedic Foundation to work on an EMS community benefit and financial distress tool project. And the purpose of this is to build tracking tools for EMS agencies so that they can take a look at their costs and benefits, track some core financial indicators. In our state, in Kansas, they're already reporting quality measures to the Board of EMS. And I'm going to keep saying Board of EMS even though I recognize it may be different in other states. But one of the things that we wanted to do was to start to get them to report on financial measures as well to get an idea of agency financial health, which does a couple of things. For the agencies and their communities, it gives them a lot of information on, what are the actual costs of their service, and what are the benefits that the community is getting out of the services that the EMS agencies provide. And that can be helpful when they're talking to, county commissioners or potential grant funders, or people who want to know, what exactly are you doing and what are the costs and what are the benefits. And these tools will help them to be able to present that information in really concrete ways. From the state flex program perspective, the reporting of that financial data to the board of EMS will enable us to start looking at where some of these agencies are from a financial health perspective, and then we can start to target and tailor some of our projects to the agencies that are most in need. And kind of as a corollary, we can also sort of sell the use of these tools as a way to participate in some of the programs or projects that we might want to do, and that will again increase the quality and the amount of data that's available to us, that's available to the agencies, and so we're hoping that we can create sort of a positive feedback where they want to use these tools, and then we can show them how using those tools is benefiting them in their work with the state. Next slide, please. Oh, there we go. So what's going well? So initially, there were going to be 2 tools that were going to be developed. And Gary Wingrove at the Paramedic Foundation has let us know that he and his accounting wizards have managed to make it into a single Excel spreadsheet. So the agencies will be working with just a single tool that's got all of the survey information, reporting information in it, so they're not trying to work with 2 separate things. I think that's going to make it a lot easier for them to use, and it's going to be a bigger selling point, I think. If they just have one thing that they need to be using. So that single tool is going to be alpha tested this month with 2 agencies in Kansas and 2 from Ohio. And based on the results of that testing, the Paramedic Foundation will take the feedback that they get, they'll refine the tool. There will be a beta testing phase, hopefully in June, with a larger group of agencies. That will again come from both states. And then again refine the tool based on their feedback. There's also a plan to develop an instruction manual for the tool. So the alpha testing will kind of be the best guinea pig mode. Here, use this, see how it works, and then let us know what you thought. And that, I think, will be informative for figuring out what exactly needs to go in the instruction manual and how it needs to be discussed. And then finally, the goal is to be able to put this out for all the state flex programs to use come September. So we're pretty excited to see, what kind of feedback we get as the testing phases go forward, and then to see the final thing take shape. One of the biggest successes for us has been the conversations that we've had with partners to identify potential agencies that would be interested in helping us test the model, getting connected to them. I'm fairly new to the program, so I haven't really talked to any of or very many of the EMS agencies in the state, and so it's been nice to be able to lean on our existing partners to connect me with some names and faces that I haven't talked to before, and be able to talk to those new people about what we're doing and how we think they can help us, but also how we can help them. So that's been really neat. And we're hoping to continue that momentum, not just in this particular project, but as we move forward into subsequent projects, particularly in the next Flex grant period. Next slide, please. we don't have a lot of lessons learned yet because, as I said, the alpha testing is going to be happening this month. So I think that'll be a good set of lessons learned when we get that far. But a couple of things I could say now, and I would even apply this to subsequent projects that we do with CMS agencies, is that from our state flex program perspective, I think that we could have done and could still do some more marketing or education and outreach sort of activities to tell agencies who we are and what we're doing and what we're hoping to accomplish in doing some of the EMS-related projects through Flex, and also help them to understand why we are focused on the things that we are, why we think this particular tool is going to be a good thing for them and not just for us. And so I think in the future, one of the things that I've been thinking about is how we can do a better job of sort of selling the activities that we want to do in the Flex program. And we've sort of started to do that with some of the things that we're looking at into the future, but I think that there's a lot of potential for increasing agency knowledge of the kinds of goals that the Flex program has, the kinds of projects we'd be interested in doing, how we get those things started, what kind of information we would need, but also what kind of benefits they would see from participating, from gathering data. And I think that will help us be able to recruit participating agencies that much more easily in the future, because our name will be out there, our ideas will be out there, there will be a bigger knowledge base for the benefits of looking at some of these issues, the EMS rural issues, and working through the Flex program to address some of them. Are there any questions? Ohio, do you want to add anything?
Just a reminder for the Ohio folks, it's star 2 to unmute your line if you wanted to. Yeah, go ahead.
I'm on. No, Tracy, I think you did a great job. One of the great things about Flex and this project in particular is being able to share it between states. And when we're making a toolkit, the fact that, I mean, there's not much of a difference between Kansas EMS and Ohio EMS as far as financial sustainability and metrics. So I want to thank Tracy for spearheading this.
Yeah, this has been pretty interesting. I'm really, really interested to see how the tool comes out and what the agencies have to say about it.
Yeah, Ohio is too.
Awesome. Well, thanks, guys. If there are no further questions, we'll hear from Terry Cadle from Alaska, from the Office of EMS, Department of Health and Social Services at the Alaska Rural and Community Health System. Star 2 will unmute your line.
Hello, this is Terry Cadle. Thanks for giving me the opportunity to speak about our Alaska Flex EMS project. So our project currently, if you can switch, if you take a look, Alaska, that's some of our road systems that we have in Alaska. So we have rural, lots of land spans, as you can imagine. And our project, next slide, please. Our next project, basically this project is to integrate EMS, critical access hospitals, and neurologists, and interventional neurologists, which is only located in one city in Anchorage, Alaska. So what we're doing with this project is trying to integrate EMS with an interventional neurologist in Anchorage through telestroke, and we're using right now on the slide that you can see, we're using for this test project, we're using the lower Kenai Peninsula as our area for testing between 3 departments. And the ultimate goal with this right now is to reduce time between the field and appropriate treatment, and potentially integrating or in bypassing critical access hospitals. Next slide, please. So this slide right here for steps for implementation. We have medical direction from the state of Alaska, Dr. Mike Levy. We're also using a neurology group, Dr. Lada, to develop in-field protocols for assessing the potential for large vessel occlusions, and that's going really well, and we're implementing protocols for the 3 departments that are involved with this test program, and then we're integrating with protocol with the critical access hospitals to integrate more rapid transport to an appropriate facility. Next slide, please. So implementation has been education of the EMS system and the pre-hospital providers with protocols that are appropriate, using both the VAN and the BFAST assessments, and then communication with critical access hospitals in Kenai to be able to have them on board as a stakeholder with this project, and then also integration with the neurology group. Next slide, please. This is an example of the BFAST, so it looks at balance, eye, face, arms, speech, and time. And then the second assessment, next slide, please, is the VAN. And VAN is using vision, aphasia, and neglect. So that's taking some treatment potential for, it has a high success rate for identifying large vessel occlusions. Next slide, please. For implementation has been mostly to try to educate providers of the critical access hospital, and then also changing protocols with the medical directors of the 3 EMS agencies that we are working with for this test project. Next slide, please. And current barriers to overcome has been some aspects of the technology has been a platform for the program. That has been the largest barrier. Communication and the remoteness, connectivity has been identified, and we've already overcome that, and we're working with another company to try to ensure broader communication capability in most rural parts of Alaska. So the biggest one has been identifying a platform to be able to run a telestroke program on. That's been the biggest barrier. Next, please. Next slide. Oh.
That's the end of your slides, Terry, but you can go ahead and talk for, go ahead and finish what you're saying. I told you you only had 5 minutes, but we do have some extra time, so if you want to keep talking just a little bit more, that's just fine.
So the next steps with regards to our project is after we have our platform, we already have the training in place, the critical access hospitals in agreement as well as on board with this project, and everyone sees the advantage of getting potential stroke patients who have been identified by our 2 assessments as a potential for large vessel occlusion quickly to the most appropriate care facility, which would be here in Anchorage, where an interventional neurologist can go in and hopefully remove the occlusion to reduce the negative effects of having a stroke. So that are the next steps, and also implementing the actual play of the plan for a telestroke program. Are there any questions?
Star 2 will unmute your line to ask Terry if you have any questions about the Alaska program. All right.
Hearing no questions, I'll go ahead and mute. Thank you.
Absolutely. Thank you. All right, Nicole.
Yep. So this is Nicole again at Tasc. We also invited the Florida Flex program and the Utah Flex programs to come and give an update on their projects. However, they were unavailable to actually come and present. So they provided me updates, and I will go through them a little bit for you guys. And if you have any questions, I probably won't know the answer. I can put you in contact with the person to talk to, though, and I believe their contact information is included in their slides. But I have been talking to these, actually all of these states I've been kind of keeping in closer contact with and hearing how their projects are going and doing rapid reviews and that sort of thing. So starting with Florida, their FY18 EMS sustainability project included a couple of different objectives actually, but a big part of it was related to data. So the A and B there, you can see that they were going to take a look at the current performance measurements that were in use in their state that EMS agencies were already using. They also wanted to take a look at EMS compass measures to evaluate if Florida and the rural EMS agencies in Florida would be capable of accurately reporting them. And then also another objective of their sustainability project, not necessarily related to the data aspects, but was to increase the number of community paramedicine programs in rural counties. So some of the activities involved in their program involve developing and validating additional areas of measurement with the rural EMS stakeholders. The EMS director there told me about how they implemented a performance measurement monitoring system at no cost for the rural EMS providers and showed them how to use it. And a big part of that was validating data quality, which is, I think, described here in the next couple slides that they did have some issues with data quality. They were found it easy enough to pivot, go back, fix those data quality issues, help them report better quality data, and things are are chugging along. Improving performance measurement by 60% by supporting NEMSIS version 3 upgrades. The goals of their program, the reason they wanted to do this work was to build an evidence base of sustainable rural EMS models that support high quality care. They wanted to be able to disseminate best practices about successful models to rural EMS stakeholders, and then also facilitate development of community paramedicine programs. So what's going well with the Florida project? The majority of Florida rural EMS agencies are submitting NEMSIS data. The data is being analyzed in near real time and provided back to Florida rural EMS agencies. Steve McCoy, who is the state EMS director in Florida, he attended our small group meeting in February and was showing us the dashboards that they've been able to make available to EMS agencies, and they're pretty cool. So if that's something you'd be interested in seeing, I would recommend getting in touch with Steve McCoy. His contact information is in this presentation, and he would be more than willing to share with how they're doing it. Also going well, they've really forged a strong partnership with the Florida Agency for Healthcare Administration's Medicaid program, and have created some linkages with the State Health Information Exchange. Lessons learned. A focus on data quality needs to be implemented sooner. You can give EMS agencies all the tools, but they still may not use them. There needs to be a way to change the rural EMS culture to embrace quality. That one is something that was talked about quite a bit at our EMS small group meeting too, that there needs to be a culture change, and culture change is hard, as we all know. The other lesson learned that Steve cited was that not all rural EMS agencies embrace the community paramedicine model. So there is Steve McCoy's contact information. Florida currently does not have a Flex coordinator, but they do have a state office director as well if you were interested in talking to the Flex program rather than the EMS bureau there in Florida, but really that's who has been really running this project and helping it along. Any questions about Florida? Okay. Andy, will you put up Utah for me? Thanks. So similar to Florida, Utah provided an update for me to give on their behalf as they were unable to make it to this call today. So Matt McCullough, excuse me, the state office director in Utah provided this update. Their project assisting rural EMS providers in increasing their capabilities for assessment, triage, and reporting of stroke and cardiac patients. And really that is what it came down to, was that last part. In the 2018 legislative session, the state of Utah passed legislation requiring hospitals in Utah to be reporting to stroke and cardiac registries, which was going to be an issue in rural. So they decided to use this project to help the rural build capacity to report that data as mandated. Their project description: participate in statewide EMS stroke and cardiac performance improvement activities. They created a stroke committee and a cardiac registry committee to look at the data elements. They've outreached to and trained 17 rural county EMS providers and their rural hospitals on identifying and reporting the registry data elements. They are working on developing electronic linkages between the state EMS provider-run system and state registries, and providing grant funding to standalone systems to connect with the HIE, or Health Information Exchange system in their state so that they can be sending data to the state registries. And then at the end, they will evaluate the success. There are some of their baseline goals. Current status and what's going well. So as I mentioned, they established a stroke registry committee and a cardiac registry committee. They're working alongside of each other, but separately at the same time. They're identifying the data elements, creating a data dictionary, and determining the software systems that will be used. The EMS data manager in Utah has been visiting rural EMS agencies, and I think the next slide actually shows that they've been to 7 or so communities and the number of agencies within each community. They've engaged their CARES registry contractor to participate with the registry committee, so keeping that person in the loop. Their state EMS medical director is strongly engaged with both of those committees. And they think that the data then is going to help drive the revision of the guidelines for EMS in the future. I know with this program they are using Get With the Guidelines for hospitals and EMS agencies that have a little bit bigger volume. For those that didn't have the volume to meet the guidelines of reporting, that's where they actually provided a reporting system for them to use so that they would be able to meet the mandate as well. So according to Matt in Utah, what's going well? Like I said, 7 counties or so have had visits, including the number of agencies within each. Agency data is reviewed with the service director or data manager working to improve data quality and timelines, focusing